Good evening, good morning, whatever, depending what time you're listening to this. Hello, everybody. Thank you for joining me on the next episode of the Dental Implant Podcast. And this is actually going to be another collaboration with the Zaga podcast. And I am very, very honored and very excited today because I have my friend David Pastorino here as well. And if you place implants, if you place zygomatic implants, you will have 100% heard of my other guest. We have Carlos Aparicio joining us today. Gentlemen, thank you very much for joining me this evening.
Thank you, Pat. It's really a pleasure to be here.
Yeah. So Carlos has very kindly offered to come and answer some questions for us, basically. So I did Carlos's course. In fact, when I came out, I was hearing rumors of of a COVID-19 starting. So I did the course in January, and I was like, should you be going? Should we not? I was like, no, I'm going. It's fine. It's not a problem. Nothing's going to happen. So that was that long ago, basically. And I have to say, I was there with a couple of colleagues as well. And these colleagues had done other zygomatic courses as well, particularly hands-on. And they said that this course was just absolutely fantastic by comparison. And obviously, my experience was the same as well. The level of detail we went into was just absolutely superb. So you gentlemen, you have a very good course there. One of the things for me as well is as we study, as we progress, as we learn, there's always more questions which come up. And this is one of the reasons why I've asked Dr. Aparicio to come on the podcast today so that we can answer some of these questions, basically. And I think probably a good place to start, Carlos, if you want to maybe give a little bit of your history and background, but I think one of the things that one of the things that I wanted to discuss today as well was the Zaga concept. Where has it come from? Because people think it's a technique, and that's not quite correct. It's a classification. It helps you understand what techniques you need to apply to different cases. So if you could explain a little bit to us behind the history so that we can start to build up a picture.
Thank you. I think this is a very, very not only interesting but important question. I think if I go back in my history, I think I was very honored to collaborate with P.I. Brannemar in the latest 80s. But I didn't know in the first case, as I know, rehabilitating a maxilla with zygomatic implants. But to me, I didn't understood anything at that time. Then I had the pleasure and also the honor and the privilege to be trained by Chantal Malabeth. She told me that it was just 1 year she was practicing zygomatic implants at that time. So she told me what she had at that moment. So, and it took me like 8 more years to understand that we didn't need anything. We had at that time problems, and we didn't know from where those problems were coming from. So it was about making a hole here and then finishing on the zygoma with some very primitive rules. It was something not protocolized, not teachable, I would say, not teachable. So it was like a rough model, plastic, thick model, and then you had to make a hole from there and end there. And that was all the teaching. That was all the teaching. Although I have to say at this moment that Pierre Brannemar, who invented the technique, merits all my credits for sure. But this was the idea of finding a remote place to anchor an implant when there was no bone where it should be. So it took me, as I said, like 8 to 10 years to understand that a very simple thing, very stupid thing, is that about we all are different. So it's so simple and so long way to understand that. And then at the moment I understood that we all are different. I understood also that the technique couldn't be the same for all the patients. So I understood at that moment that we should adapt our technique to the patient's anatomy. And now it's so simple. And when I remember this, I think, Carlos, you were so stupid. You didn't. Why you? It took you so long time to understand that, but it is like that. So at the moment we understood that, everything was more simple. We understood that in some cases we should go intravenous, as PI told us. In some other cases, we should move a little bit the technique and go in a different direction. And then finally, in other cases where the atrophy is so huge, we should try another pathway for our implant. But then that was the beginning, really. This is because of the this Zaga classification. We understood that all the patients are different, and we understood that the technique should be, the implant path should be different also. But then we understood that we were on the beginning of our understanding of the technique. So we understood also that if the patients are different, the conditions are different also, and we developed this Zaga concept, which is more than the Zaga classification, for an holistic way to understand this kind of rehabilitation. So the Zaga concept also takes care about the prosthesis, takes care of the management of the soft tissue, takes care of how we are going to maintain and preserve this soft tissue and this small amount of bone. So it's how or why, if the patient is different, why we should use the same implant for all the patients also, which is something very contradictory also. We get about hundreds or maybe thousands of different types of regular implants, and we have like or two models for zygomatic implants, even though the anatomy is much more complicated, the zygomatic plate. So still, we are developing new things. For instance, I like to mention something that a new, I would say, a new way to start with the surgery, which is a new way to make our first incision, that our friend and Zaga Center of Cardiff, Guy McLelland, developed very few months ago, making this Zaga roll flap on the palate side, so we get more connective tissue on the buccal side. So we are still developing, because this is nothing that we have like arrived to the end. We are trying to improve this kind of rehabilitation. And this is the essential of our Zaga network, to collaborate, to use collaborative intelligence to go more and more and more, and to be more precise, and finally to be able to teach this knowledge, which is, to me, the most important part of the Zaga concept. We try to put the concept in a way that are teachable. I had not this chance. It took me so many time for that, because I had not that chance. And this is, to me, this is what we are doing now, and this is what motivates myself to keep on this trail.
I think the few bits that I've taken away from that information already is, firstly, we all stand on the shoulders of giants. Okay, like you were mentioning that, you were taught by PI Brannemark, I've been taught by yourself, and it's a constant progression. I think for those listening, is they need to understand is, as I said, the Zaga concept. It's not just this is how you place an implant. It's an all-encompassing, or it's aiming to be an all-encompassing protocol, where you think about the restorative, you think about the longevity of the implants, you look at the anatomy, and then you make a bespoke treatment for each patient depending on their anatomy. So it's not just, place the implant, we're done. It goes into a lot more depth than that. And I think the other thing that I really like as well, Carlos, is you're a very humble person. You constantly say that, you know what, this is always something in progress. This is always something that we're refining, which again is very important. And this is something that I've mentioned in previous podcasts as well. As soon as we think to ourselves, we know, we understand everything, we stop our own learning. So it's important we keep our minds open in order to keep improving the patient care as well. Okay, so that's a little bit of the history of the Zaga concept. Could you touch, please, a little bit on I think just a brief overview of the Zaga classification as well, and how that modifies your implant trajectory. And then I've got another couple of questions after that as well for you. So if we could go over briefly over just the Zaga classification, please. Yeah.
Okay, this is the simplest question actually. So it's, the Saga classification essentially means that we have to. Allow me to go one step back.
Yeah.
I think in life there are acts that are reversible and acts that are unreversible.
Mm-hmm.
So, for instance, when I take impressions, this is a reversible because if my impression is not good, I will repeat this impression, and that's all. I have a teacher that told me if you doubt about the precision of your impression, use the best instrument that you may use, which is a hammer. So if you doubt, you take the hammer and destroy it. Okay, that's a reversible act.
Yeah.
But there are other acts in life that are unreversible, and in our profession, maybe drilling is an example of an unreversible act. Once I make a hole, this is done and is there. Once I take my knife and cut, it's cut it. So I think that the message of the Saga classification, to come back to your question, is not, to me, it's not important, so much important to classify this is 0, 1, 2, 3, whatever. It's not that. To me, the message is, again, that we are different. So before performing an unreversible act, as it is cutting or drilling, please sit down, understand what is the anatomy of your patient and what is the anatomy in this specific site, because it may have this anatomy here and on the left side a different anatomy, or in the front for sure it will have a different anatomy. Understand what structures you are going through, and then once you have this in mind, decide from where you are going to drill or from where I'm going to cut first. So then we will find different types of anatomy. We will find situations where the remaining alveolar bone thickness is enough to go through it, which we call it Saga 0 or even Saga 1. And in those cases, we like to perform our osteotomy through this small amount of bone, because if it is, I mean, if always thinking our mind should be focused that we are talking about zygomatic implants, and for sure to say that in this trajectory or virtual trajectory we are planifying our implant, finding 5 millimeters of bone in an oblique trajectory is a lot of bone, okay? But we shouldn't think on regular implants. We are thinking on zygomatic implants in a situations of atrophic maxilla. So whenever I find in my virtual planning, whenever I put this oblique plane, which is not perpendicular, because in perpendicular maybe those 4 millimeters, 5 millimeters are 3 or less. But when I incline my plane, those millimeters become longer. When I find those, let's call it adequate amount of bone, and we go through this bone, and then we try to get stability far away on the zygomatic bone, but we are sure if this implant has an adequate design, And with adequate design, I would say if this implant has threads on the neck, and we are able to stabilize this implant far away on the remote position, on the zygomatic position, and this neck of the implant is wrapped with those 4 millimeters of bone, I think that this will be enough to get osseointegration there, and this osseointegration will prevent for oroantral communication in the late future.
Hmm.
So that will be my first option, and this will be Zaga 0 or even Zaga 1, even though the implant in Zaga 1 there is a little bit more curvature on the maxilla, and then a part of the implant can be seen on the outside. When it comes to what we call Zaga 2, Zaga 2 means that this is something like in between. So we have some bone there. We may try to make a tunnel osteotomy, or but we are not sure if we make a. By the way, I didn't explain what is we call tunnel osteotomy whenever we can make an osteotomy that is circular, and we make a tunnel with an entrance and an exit. And for sure, when we make a hole, let's call hole to the osteotomy. When we make a hole which has a circular section, we need a circular section also to close this hole, this osteotomy. This is why we use a circular section implant to close a tunnel osteotomy. And this happens in situations like Zaga 0, Zaga 1, or even Zaga 3, when I will explain a little bit more later on.
Hmm.
So Zaga 2 is this situation where is not once is not the 4 where the atrophy is extreme, is not the one where we find some bone. So Zaga 2, you do your best. You try to be conservative, but usually you will end up with not totally complete tunnel. We will end up with a very deep channel, probably, but not a totally deep channel. For those situations, we always try also to, as usually, to be conservative on the osteotomy, and the implant will be more exposed to the buccal side on his middle part. And then we go to the Zaga 3. Zaga 3 is the situation where we find those triangular remains of alveolar bone. Triangular remain of alveolar bone that usually has some kind of inclination, buccal inclination. So is not enough to place a regular implant, but you can go through this bone and still you may preserve some bone on the buccal part of the alveolar, and then anchor the tip of the implant on the zygomatic bone. The good thing in this type of anatomy is that if you are conservative, you can preserve some bone wrapping around your implant. I'm not telling that it's going to totally wrap around the whole neck of the implant, but this small remain of alveolar bone will be able to provide the soft tissue fibers a place to attach in. And
Hmm.
this is a very fantastic thing. So I hate, and sorry for using this word, but I hate those teachings that say the first thing you have to do is to destroy the bone in a perpendicular way. And because this is, first of all, the problem of this patient is an atrophic patient. His
Hmm.
maxilla is atrophic. So what the hell I should take more bone that I will need to.
Yeah.
But if you, on top of that, if you discard this alveolar bone, you are knocking the door for the soft tissue complications. So preserve as much bone as possible is the message of Zaga 3. So I know that is a triangle, is a very ridiculous amount of bone that you are left in there, but if we can use it, there is a very big rationale for using this bone in order to support the soft tissue fibers to attach in. And then that's the beauty of this philosophy. Then finally, we find the Zaga 4, where mm, we have just 1-2 millimeters of bone. There is nothing. So I'm very reluctant to get a palatal uh, pathway, because I know in my experience, in others' experiences, that in the future this bone is going to resolve. So we are trying to prevent the soft tissue, the oral-antral communication. But then in this balance, that in one side of the balance has the soft tissue problem, and on the other side of the balance we have the oral-antral communication. So we have to decide from which side we have to we like to reach the more. And usually we we give more importance to the oral antral communication, because especially today, because today we have the new designs of implants that you for sure you know. This flat design of implants together with the uh, design of the channel osteotomy, and also together with the new instruments we have today, because I had to learn in the hard way. So nobody told me how to use a very stupid thing. I'm going to say very simple thing now. Nobody told me how to use the round bar. The round bar is an instrument very difficult for a dentist to use. I mean, no, allow me to say, because we are dentists, we are accustomed to use the round bar in a way. But when a dentist uses a round bar for a zygomatic purpose, it's always wrong. It's always wrong, because he thinks he has to go forward and he has to work backward.
Yes.
It's just the opposite, and it took me so long to understand that. When I was trying to preserve the membrane, I failed 50% of the cases. I make a hole on the membrane. So until I understood how to use the round bar. We are very lucky today because we have lateral and cutting bars. For instance, Versat bar is very good to preserve the sinus. Very easy, much more easy than with the round bar. I can do it with both, but it's quicker and safer. In this balance of the oral ultra communication in one side and the soft tissue on the other, we try to give more importance to the oral antral communication. Because, as I said, for the soft tissue, we have first our way to prepare a channel osteotomy. So we are able to sink the implant, to dig the implant, and almost our implant is not protruding against the soft tissue. Plus, we have this flat design of a Zaga implant, of a Straumann Zaga implant, which is, as you know, has this flat surface. With the surface is extended, and plus is soft, is flat. Sorry, and plus we have developed some tips like the roll flap, tips like the scar graft. Some tips, we know that the importance of the connective tissue to protect our implant. So in this balance, we have more resources to escape from the soft tissue complications than from the oral-antral communication. So we move in the Zaga type 4. We shift our osteotomy to the buccal side, and we try not to disturb this what we call zygomatic implant critical zone homeostasis. Yeah.
Yeah, thank you, Carlos. So again, it's. I mean, this is nicely moving on to my next question. But one thing that I've taken from this discussion already is that, obviously, in your experience, you're saying that, particularly in Zaga Class 3, when you've only got a little bit of bone that's left, and I've seen it a lot where people just use a lateral burr and just completely get rid of it. And you're obviously very much of the opinion that, as difficult as it is trying to maintain that little bit of bone, we have to try, because if we can maintain it, it's going to help support the soft tissue. And then obviously the next step on for that is as the maxilla starts to become more and more resorbed. And again, this is a nice thing about the Zaga concept, is it's not just a classification and you do it, is we're thinking about the next steps, we're thinking about longevity as well, is the zygomatic implant critical zone. Now, please correct me if I'm wrong, because obviously I've just taken this from what I've read predominantly from your book. But particularly in these resorbed cases, the whole point of the zygomatic implant critical zone is that's the bit near the head of the implant. And what we are trying to do, which is what you've already stated, is we are trying to prevent a long-term oroantral communication. Because if we get rid of that really thin eggshell bone and there's bone loss in the future, you end up with an oroantral communication, which is very, very difficult to treat. So you've already alluded that what happens in those cases is you move the head of the implant slightly more buccally to try to reduce that risk. Is there anything else that you do in addition to that? Because obviously you've touched on the point that if we're moving it slightly more buccally to reduce the pressure on the soft tissue as well, that's where the Zaga flat implants come in as well. Is there anything else that you can add to that? Do you have any more thoughts?
Yeah, thank you for reminding me, because we have defined this zygomatic implant critical zone as the zone where the implants meets for the first time the alveolar bone or the remains of the maxilla bone. And the zygomatic implant critical zone is formed by the bone, by the implant, and by the soft tissue too. So this is like an ensemble of the three parts: soft tissue, bone, and implant. And then depending on how much bone we find, we will create one or another type of a zygomatic implant critical zone structure. In the case of a Zaga 4 situation where we have almost no bone on the sinus floor, we may find like 1 millimeter of bone or 2 millimeters. We try, as we were saying before, we try to shift our osteotomy to the buccal side, and we try to. And at this moment, I would like to use another word, which is different from osteotomy, is anthrostomy. Anthrostomy, just for the audience, is the place where we get into the antrum. So in a case, Zaga 4 type, where we have no bone on the sinus floor, we try to elongate, to separate the zygomatic implant critical zone from the anthrostomy zone as much as possible. This is what we try to do in addition to what we have explained to now. So it is mandatory, it is so important, it is critical to maintain the sinus lining integrity at the zygomatic implant critical zone. And then we try to make this channel preserving the Schneiderian membrane as much as possible until the moment we create the anthrostomy zone, until the moment we get into the antrum, because we need to get into the antrum to perforate the zygoma. And this is a requirement, of course. So what we try to do is to separate this distance, to separate the anthrostomy, the zygomatic implant critical zone, to the anthrostomy zone as much as possible. And then we know that by separating the two zones, the risk for having this contamination decreases a lot.
Okay.
But with that, and I think I should insist on that, we need a specific implant design, an adequate implant design. What do I mean with that? We need to preserve the bone at the, even though it is so few at the critical zone, but we need to preserve it, and for that we need threads. We need threads on the implant and stability on the implant. If the implant is right stable, totally stable and has some threads, we can preserve the bond because we are inducing osseointegration. We are creating secondary stability, even though it's not very powerful, but it's enough to maintain the bond there.
Yeah.
So we are not relying only on the weak soft tissue sealing, which I like it very much. I'm not depreciating it, but I prefer to have soft tissue and hard tissue sealing for my implant.
I mean, this is fantastic. I'm learning so much already. It feels like private tuition for me. Carlos, there's another question that I have for you, and I think this will be very interesting to a lot of my listeners who either don't place zygomatic implants or they're starting to learn how to place zygomatic implants. Is in your experience and with the data that you understand, is at what point, what alveolar height and what alveolar thickness should we start to at least think about zygomatic implants? Because I've seen a lot of cases. I've had some cases of my own. I've got some cases which have been referred to me where dentists have squeezed conventional implants in. There's been complications. The implants have had to be removed. And now what would have protected the head of the zygomatic implant, now there's nothing left. That makes it more complicated. So
That's a very complicated answer.
at what point should we, when we're looking at a CBCT scan, when we're looking at the alveolar height and thickness, at what point should it enter our head that we should at least consider zygomatic implants?
Okay, allow me to go a little bit on the air because, as you know, we should have a overall vision. No,
Yes.
I cannot tell you if in this point is because the rest of the mouth it's important. Okay, so we have to imagine a very uniform remaining of alveolar bone where in all the parts we have the same height, or we cannot tilt an implant. Oh, okay, I will say first, I'm very conservative guy. So if I can escape from zygomatic implants, I escape from zygomatic implants. I would say more. If I can escape from implants, I escape from implants. Because to me, the best implant is the tooth, the natural dentition. I love natural dentition. I mean, this is a message I will say, I will give for young people that natural dentition is a pleasure. I mean, everything is so easy with natural dentition. It's so rewarding. And the business, your business will stay forever because I remember now, my father was a dental technician and my grandfather, he was too also dental technician. I remember one of the dentists working with my father, he used to say, he was an old dentist at that time, so probably he was already working with my grandfather. He used to say, if there is a tooth, there is a business.
Yeah.
I mean, if there were no implants, anything at that time, but he used to say, if there is a tooth, still there is business. And I will give this message, if you are only thinking in the business, the teeth is the best business and the most rewarding. The most rewarding. I hate this new fashion of taking out everything and placing two screws. I hate that. I think it's a pity. It's a pity. We are like losing our job because with natural dentition we can do, I mean, unbelievable things,
Yeah.
and still. So if I can escape from zygomatic implants, I try to escape from them. But say that I'm becoming more fan of quad zygoma than before. And I going back to your question, I use basis in this conservative philosophy I have. I used to place sometimes. You, okay, the two posterior were very clear because there is no bone, and the anterior get like 8 millimeters or a triangle with some palatal entrance. I used to place regular implants on the anterior and try not to make a quad. Now I'm going more for the quad directly when I'm doubting When you doubt, can I place a regular implant on the anterior or not, then I go for the quad
Okay.
because I feel much more comfortable, much more secure with the quad. I got I had more failures in regular implants. So they call now hybrid regular. So meaning two posterior and some regular in the anterior. I got more failures on the regular implants than on the zygomas.
Mhm.
So now I'm going more for in those situations when I doubt, I go for the quad. And if the origin of the question is what is the indication for regular implants, I think the quad is the queen. I mean, the when you don't get anterior bone nor posterior, and in millimeters, let's say on the anterior, something less than 5 millimeters, I think is today. I will go for a quad.
Okay.
Yeah.
Okay, fantastic. So, I mean, those were the main questions that I had for you. But what I would like for you to do, if you still have a few minutes, it's I know that you, David, you had some questions as well. But could you tell us more about the Zaga centers? What's the history behind it, and kind of like what your aim is for the future? Because obviously, as I said, I've done your course. It's something that I'd like to do again, and I know that you're growing this network, and I'm seeing the network grow, and it's fantastic. So, could you tell us a little bit more about that?
I will tell you this with a condition. I will start the answer, and David is going to finish if you allow
Okay.
me to do
No,
that. Okay.
I was planning on something different actually. I was planning on tricking him to answer the question, and I'd like to start with one question that it's actually a pleasure to have Carlos on the podcast because he can't escape from my questions now. And you mentioned Carlos in the very beginning that you were lucky to have Pierre Brandemark as mentor, and then Chantal Malevez as a teacher. And one thing that we're missing in this story is how did you get to the zygomatic implants in the first place? What was your first contact with this? At the time, maybe not a treatment option, but this invention, I think we could call it at the time. What was your first contact? Why or how did you get in touch with it?
I'm taking this opportunity because then I will escape from another question. You were talking about the patient you remember always. Uh, this is the story of the my first patient with zygomatic implants. Actually, it was 80s, around 86, 87. So, I mean, allow me to explain a little bit more. I'm talking 86, 87. I learned implants I had my first contact with implants in 83, 84. So at that time, not even dentists knew about the implants. I'm not talking about patients, not dentists. There was a small book, and a small compilation of sheets like this with 160 names on the wall, having taken the course of zygomatic implants in Sweden, and in those names it was, for instance, Eugene Keller from the Mayo. I mean, people at that level, no, at that level. So, what I mean is that at that time we have to uh, perform surgery in, if I remember correctly, was like 20 mandibles, edentulous mandibles from more than 1 year edentulous, not extraction, no. 1 year edentulous, and then you were allowed to place implants. Then we have to perform 20 low jaw surgeries before they sell us implants to work on the upper jaw. So it was at that level. And the implants for the upper jaw, don't think they were very different, were a little bit longer. That's all. So 3 years later, it showed up in our office because at that time I had a partner, Jordi Oliver. It showed up in our office a young man, about 18 years old, young man. He lost his premaxilla totally because of iatrogenic maxillofacial surgery. He had a open bite, and they were wrong on during the surgery. He cut the premaxilla. Well, total error. They cut the vascular apport, so he got a necrosis of the premaxilla, and then he lost the premaxilla with a oronasal communication of about 2 centimeters. So it was a disaster. Imagine a young 18 years old guy. And then he told us, "Can you do something for us?" So, wow. So he wrote our master, our teacher, Pierre Waremar, some radiographs. And he said, "Oh, yeah, come here." I said, "What? What is the? He's getting crazy, this guy. He's getting crazy." But, well, finally, he was, he was not poor, but with the limited economic resources. So we were able to manage the government paying his, because it was an error, paying the travel for him. So we went to the Gothenburg University where P.I. Weimar was working, and then he himself he used to have a machine, in a turning machine in his office. So he, doing with the hand like this, he turned two implants, long implants like that. And Ignacio was the name of the patient. Was very lucky because at that time, Eugene Keller from the Mayo Clinic was spending a sabbatic year in Gothenburg just to learn, regular implants. Because now we smile, oh, we get 1 day course and then we are expert. No, he spent 1 year, the chief of the Mayo Clinic maxillofacial department was spending 1 year to learn regular implants in Gothenburg.
Yeah.
And I said Ignacio, the patient, was very lucky because Eugene took care of him. He closed the oronasal communication, and PI and him, they took a piece of his hip, and then they used the implants to stabilize the graft or the cyanomatic bone. And then we rehabilitate the case. We perform this. So this is the patient I remember them all because at that time I learned two critical aspects of dentistry to me. One was that there is a remote anchorage for those implants, which is the zygoma. And the second is that no matter if you place the implant right, perpendicular to the occlusal plane, or you tilt it, it works. And this was to me also the initial thinking of the tilting implants. So thank you, David, because it's a very important
Love story.
Yes.
Love story.
And that goes a long time back, actually, 85, 86. I think I wasn't born yet, to be honest. And so then something very happened in 87. I was born, but and then you went through. So you grew different innovations and techniques in dentistry. I'm thinking of on the clinical aspects, tilted implants. Obviously, zygomatic implants are a big part of your contribution to dentistry, and on the business aspect of things, to have the first multi-specialty clinic in Spain, which was a big thing at the time also, a street level clinic, which was also something very different, and all of that takes me actually to the key question that I have here. And I will ask you this question and I can go on with the answer, but the very beginning is something that is really of interest to me, which is how, where, when did that idea of a network of Zaga centers come to your mind? What was the need? What was the idea? What was the little thing that made you invent or imagine this network?
I have to say first, you mentioned that I created a multi-specialty center at that time. We call it a dental hospital, but it grew too much to me. And then in a moment, I have I call it a fiancé that told me, "Carlos, we love you." And then I said, "How much do you love me?" So I I sold the office. We were like 54 people on the office. It was very nice because we worked as a hospital. As I said, we have every Wednesday we had a meeting. Everything was written, protocols written for everything. So we were working like 2 periodontists, 3 prost, 2 orthodontists, endo, all as maxillo, all the specialties there. And but with written protocols, that was very nice, very good. There was a person in charge of modifying protocols. No, everybody had to work following the protocol, and if you go to a course or to a symposium, whatever, you bring a new idea, you have to comment it, then expose it, and then either can be accepted or not. If it is accepted, we change protocols, and now everyone will work in that way, or if not, you are not allowed.
This is in a way what's happening to the Zaga concept right now, right?
I would like to, but then, as I said, in a moment I got free. I think I'm a free bird now. So this dental hospital, I sold it, and then I had to stay for 5 more years, and then I started to. I mean, I think you have it on your blood, the dentistry, no? At least myself. So I started to limit my practice just to zygomatic implants. And in a moment, I realized that I was able to teach it. I was able to share my knowledge in a very protocolized way. And I thought, okay, Carlos, you have the privilege of building a legacy. But this is a privilege, but it's a very, can I say, hurtful, painful opportunity, because once you decide to share it, you have to share it, and then it's a lot of effort. It's a lot of pleasure, but a lot of effort. But in a moment, I decide to build up this legacy and to share what I know and to make it teachable. And then the same moment, I was sharing those thoughts with a person that which is Jaume, and Jaume is a person that is an important part of Zaga Center, because he is a professor on entrepreneurial, and he explained me that such an idea needs to have an organization. So you may have an idea, but this is very romantic. But if you want to put it in practice and you want to be effective, you have to create an organization. So this was the initial thinking on the Zaga centers. And maybe you can end up with a question and then explain what is the rest, David.
No,
that was the condition at the beginning. What do you think, Pat?
I think the whole CBCT scan of Zaga centers as an organization could be material to another podcast. But I think one important aspect that I'd like to mention is that you started with the idea of a legacy that in many ways is going to be met or already partially met. And also something else happened on the way, is that this legacy or this organization turned into a living animal in a way. Someone knocking at the door and saying, hey, this Zaga concept we should change this step because this works better, and we get the cases. And I'm thinking about initiatives like the Zaga road flap, for instance, which is one of them. They look into it, study it, but if it happens to prove that it prevents soft tissue dehiscency at the neck level, then that only makes sense to amend the Zaga protocol and make it a living protocol on the go. So I think that's one of the side benefits, or the main benefits or consequences of that very first idea that you had in the beginning. And that's it. But I think the CT scan of Zaga centers should be subject to another episode. You know what we do, how we do it, just to keep focused on the topic today and get to my last question, which you won't escape off either, which is you mentioned that you have dentistry in your blood, and I can clearly see that working with you almost every day. But I also know that sometimes you do something else. So what is your hobby or passion when you're not writing scientific publications when you're not changing protocols or performing surgery? What do you do?
Are, are we talking about sex now? Or?
No, no. That wouldn't be fit for a podcast, but that could be an activity. But if you can tell this a bit more romantically, that would be ideal.
No, for sure. For sure. I like sailing. I like sailing. That's my passion. That's my passion. Yeah. Uh, I mean, when I'm sailing, it's like I like to go sailing every Saturday when I'm not trapped in a course or whatever, and we race. We are like 25, 30 boats, amateurs for sure, but it doesn't matter. We go every Saturday, so I meet the crew at 10:30, and then we have like a 1 hour like training and preparing, and then at 12 the clock starts, and then we say in Spanish. I don't know if it is very correct in English, but we take our knife in between the teeth, like, and then we raise like death or life. And then those 4 hours to me are like being in, I don't know where, but I can leave apart everything, even implants, even zygomatic implants. Everything is out of the sea, and so you are with the wind, trying to understand from where the wind is coming on, from where the wind is going to come, and where is your neighbor, and if this, what is the strategy, how you can get a few tenths more speed by placing the sail in a different way, or that's sailing.
I see. It's only a few weeks. In a few weeks, you'll mount cannons on the boat to compete better, no?
Yeah, for real. What we try to be, we try to use all the legal weapons we have. All the legal weapons we have. This is the thing. So you have to study the rules and use all the legal things you may. So you can eat the wind from your neighbor. You do that if you are allowed, for sure. Sure.
So I think before diving into an illegal or doping scandal in sailing, we'll switch the conclusion, I think. Paf, thank you for joining this podcast again, this episode together. I really appreciate the clinical questions. This is amazing, and the depth of the clinical questions and conversations that you have with Carlos is, to me, enlightening, and this is a level I can expect to reach. I think we learned a lot from Carlos today. Obviously, on all the little tips and tricks, and where does the Zaga classification concept come from, and you know, I can imagine you in the next surgery thinking about this critical zone over here and trostomy zone, go away as far as possible. And I can think of you doing that. So thank you again.
Again, I wanted to say thank you to you both, particularly yourself, Carlos. I know how busy you are, so it means a lot that you're giving your time to me. I think what I would like to do in the spirit of the Zaga Center is, when I did my master's degree, my research topic, my thesis topic was on hydrocarbon contamination of implant surfaces, and there are some very easy things that we can do to greatly improve osseointegration of the implants. How we approach that with zygomatic implants, I'll leave that for you to decide. But what I will do at some point over the next day or two is I will email you a copy of my thesis. You are welcome to delete the email. You're welcome to read it. I'm always here to discuss it. So I love implants. I love titanium, and I really appreciate your philosophy, Carlos. So. People like you give me inspiration. It's hearing how you've had mentors, you've had teachers. You are now a mentor and teacher to me. So I hope to continue more from you in the future as well. So thank you both for your time this evening. It's been absolutely fantastic.
Thank you for the opportunity. I think this is like enhancing. The concept I love, the more the older I get, the more I love the concept of collaborative intelligence.
Yeah,
This is the way we are going to progress.
absolutely.
Everything that is not collaborative is not going to work. So thank you for the opportunity.
And for those who have tuned into my podcast, thank you very much for listening. If you're listening on the Zaga podcast, I have a podcast. It's called The Dental
Please
Implant.
go listen to that podcast. It's amazing.
So thank you very much, gentlemen. And we're almost bang on an hour. That's fantastic. And I will aim to record the next podcast as soon as what I possibly can. Thank you very much, gents.